Hello and welcome. I'm Dr. Will Ross, Associate Dean for Diversity and Professor of Medicine here at the Washington University School of Medicine. I'm here to talk to you about a subject which you've certainly been exposed to in your time here at Washington University, and I think will be quite relevant to your future practice. That is the subject of health and healthcare for disadvantaged communities in the St. Louis region. What I hope to accomplish in this lecture is an exposure to the variables that have led to poor health in certain segments of this population. We will explore the epidemiology of some of the leading health status indicators in the St. Louis region. And then I want to explore the unique socio-political history that led to adverse health status of these vulnerable populations. We're going to delve a little bit deeper into some of the social determinants of health. We'll give you an explanation, a definition of social determinants of health. And then I hope at the conclusion you'll have a greater appreciation of the relationships between culturally competent practices and the reduction in health disparities. Now, I want you to take a look at this picture of 3 homes in the North St. Louis region. I take our students on a tour, and during the tour we have an opportunity to get out and look around. And now you'll see 3 homes in various stages of disrepair. You'll see one to my left, broken windows, vacant lot, and then you'll see another one to my right that seems to be somewhat improved. Someone purchased a home and engaged in some significant improvements. When you assess this situation, this picture of the homes here, I want you to just use your imagination and ask, if an individual moved into that home, rehabbed that home, the one on my right, what would his or her life expectancy be simply by living in this community? Don't answer that yet. I mean, this is just a hypothetical for now. We'll revisit this. Now, what if the individual moved into this home? Now, let's go back. This home is in St. Louis City, North St. Louis City, zip code 113. This home is in St. Louis County, actually Clayton, Missouri, 63105. What is the difference in life expectancy between these 2 homes, separated by no more than 2 or 3 miles? There's a big difference. We want to talk about why some neighborhoods are less healthy than others. What are those social determinants of health that lead to the difference in health outcomes in one neighborhood versus another? Why is it so relevant? Why does zip code matter more so than one's genetic code? A lot of this data stems from the phenomenal work of Dr. Michael Marmot, who's an epidemiologist in London, who really wrote extensively about the social determinants of health. These are the social factors in which we live, work, and grow that really affect our long-term health, our life expectancy. We'll see that some homes, some neighborhoods have been under-resourced for decades. In a setting of residential segregation, there's a disinvestment in educational opportunities, a disinvestment in stable housing, and a disinvestment in the infrastructure surrounding those neighborhoods. As a consequence, you have unstable neighborhoods, which lead to unstable individuals in those neighborhoods. Unstable neighborhoods lead to unhealthy neighborhoods and unhealthy individuals. And so we can speak and work assiduously to improve the health of the individual, but we can also work assiduously to improve the health of the neighborhood, of the community. Let's focus on how we can do that. Years ago, economists at Harvard posited this concept of the broken windows theory. This was initially used to promote a certain type of policing, which has been later debunked. We won't go into this issue of broken windows policing, but it follows Michael Marmot's view of social determinants of health. If you remember that first image of those homes in disrepair, the issue is that simply living in that community, being exposed to broken windows, being exposed to vacant lots, can actually lead to adverse health outcomes. And a simple concept, actually going in, fixing the broken windows, mowing the lawn, painting the walls, can actually restore a sense of confidence to the residents of that community. They have a greater sense of empowerment. They feel better about their neighborhood, they feel better about themselves, And guess what? Their health indicators improve. Their health status improves. So a real simple concept, but it follows along the lines of really documented evidence on social determinants of health. Now, as we go on with this discussion, I'm going to introduce a couple of terms. One, health disparities. Another, health equity. And of course, we've already talked about social determinants of health. Health disparities really relates to a disproportionate burden of disease borne by a certain group, a certain community, even though they have equal access to health care. So when one controls for access to health care, there still is this disproportionate burden of disease borne by one group, a minority group, compared to a reference group, a non-minority. So if we look at this slide showing populations with equal access to health care, on my y-axis you'll see increasing quality of health care, and there's a difference. That is what we define as disparity when we control for the clinical appropriateness of health care. And that disparity is based on systems that are unfortunately designed to discriminate against certain groups, individuals. So this is the definition of disparities. Again, the disproportionate burden of disease borne by a particular group, even when one controls for access to care. Now, there is abundant data chronicling the extent of the disparities that are based on race and ethnicity. And a lot of that data was promoted in this seminal study, Unequal Treatment, published by the Institute of Medicine, the National Academies in 2002. And in this book, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, the authors posit that racial and ethnic disparities in healthcare occur in the context of broad historic and social and economic inequality, and there's evidence of persistent racial and ethnic discrimination in various sectors of American life. So let's talk a little bit more about health equity. We gave a definition of health disparities, but my colleagues in Europe prefer to use the term health equity. And I think that they're probably a little bit more on task with that, because when we speak of health equity, we're stating that every person has the opportunity to attain his or her full health potential. So I could provide tickets to a group of kids to go and visit a soccer stadium, but they may not be able to view the stadium because of their difference in their ableness. However, if I provide opportunities for them to have equal access to seeing that soccer game, then I'm promoting equity. They've attained their potential to witness that soccer game, and we want to make sure that everyone has attained his or her full potential to have the greatest health possible. Now, let's switch gears and talk about Missouri, and then we're going to drill down and look more at St. Louis, and then we're going to talk even more about what's going on at the zip code level and the neighborhood level here in St. Louis. Missouri, like most states in this country, is witnessing an increase in the Latino population and other populations. This is a changing demographics of all regions in the United States, and we're certainly not an outlier with a significant increase in the Hispanic population between the time period 1995 and 2025. In fact, since 2000, we've witnessed an 80% increase in the Latino population in St. Louis, rather than Missouri, mostly in St. Louis. In a similar vein, because St. Louis region is designated as an immigrant and refugee resettlement area, we've had a number of refugees processed here in St. Louis, starting back from the Balkan War in 1990s. We now have over 80,000 Bosnians, but we similarly have a significant number of refugees from Bhutan, Iraq, from Myanmar, and most recently from Nepal. These groups are coming in without access to normal health services, and as a consequence, they will have a greater burden of disease. And this is typically a first-generation phenomenon, but it's a phenomenon that really requires our attention. But there's another demographic which requires our attention. Remember, I gave you the definition of health equity. Everyone should have the opportunity to reach his or her fullest health potential. we're seeing that the population is a unique population, not just in Missouri, but in the United States, is not reaching his or her health potential, and that is young, low-income whites. We saw that phenomenon this past year, and unfortunately, it wasn't given the attention necessary. And we're seeing, and as a consequence, we're seeing an increased number of deaths due to diseases of despair. Well, rather, we call these deaths of despair due to exposure to heroin and the unfortunate opioid epidemic. And it certainly is, we've realized that here in St. Louis, we may be ground zero for the opioid epidemic. And in this graphic, you can see the remarkable increase in white death rates between 2000 and 2014. While African American and Hispanic death rates are certainly higher proportionally than white death rates, that disproportionate burden, that disparity persists, we're clearly seeing an increase in the overall death rates among whites. And so when we talk about disparities, we have to recognize there are many groups that are not reaching their full health potential. So why is this happening? There are certain challenges in Missouri that we should be cognizant of. We have low per capita rates of spending for public health, in fact, among the lowest in the country. We have inadequate access to affordable health care, to affordable housing. We're in the midst of this opioid epidemic. We're in the midst of this epidemic of violence. And we have a fraying social safety net, among other challenges. Missouri certainly is not homogeneous in terms of where those challenges reside. If you look at the counties in Missouri and actually look at the life expectancy based on those counties, based on the regions, you'll see within our boot heel, there's an even lower life expectancy. If we look at Pemiscot County and others, we're seeing they have the lowest life expectancy. And so there's a significant burden of disease borne by that population that we should be aware of. We're going to talk mostly about what's going on here in St. Louis and why do we see these health disparities and what can we do to ameliorate these disparities. So what are the challenges here in St. Louis? We are all certainly not surprised. Unfortunately, there's a significant amount of racial animus in St. Louis. We turn on our news, certainly predating the events in Ferguson in 2014. We know that we have needs, we have challenges, and unfortunately we're beginning to address this, but this has certainly led to a reduced likelihood of one group, African Americans, being able to receive the amount of health commensurate with their overall need, and therefore there's this disparity there. We don't have the proportionate funding to address health needs that we see in other areas of the country. We don't have the coordination. We have a substandard information systems, and our urban core is old and it's decaying. These all will contribute to impaired health, impaired access to health. We also are very fragmented. Within the city of St. Louis, a population of now only 300 and perhaps 15,000, we have 28 wards serving that small population. And in the St. Louis County, we have over 90 municipalities serving a population less than 1 million. And so we don't have the ability to really coalesce around a health strategic plan that will address the health indicators and reduce disparities across our region. And so this is really a political impediment that we can address in order to improve health equity. Our SafeNet system, the health care that we provide for the medically indigent, for those who are on Medicaid, is certainly also substandard. We're not a Medicaid expansion state. We're certainly aware of that. The last public hospital in St. Louis closed in 1987, St. Louis Regional Hospital. And we've just had a history of poor collaboration among hospital systems here. Our primary and specialty hospital care really takes place in separate locations, and there's certainly a greater need to provide more community-based care. As you can see, our SafeNet is indeed frayed. Now, let's now talk a little bit more about St. Louis and the demographics. I put this slide up because I just love the images of what we have here that's wonderful in St. Louis, the Climatron Forest Park, and of course, our lovely baseball stadium for the Cardinals. But turn to this image here. This is not a Rorschach test. This is actually a image from the 2010 U.S. Census of the St. Louis region. Just to give you a highlight, give you a reference, in the middle of this image is a white line. That white dividing line is actually the Mississippi River. St. Louis is to my left, Illinois is to my right. Each dot represents 25 individuals. The red dots represent Caucasians. The blue dots represent African Americans. You can clearly see there is a distinction here in where those dots are placed, where they reside. And there is a remarkable demarcation in the north of St. Louis along Delmar Boulevard, such that north of Delmar Boulevard, the region is almost 95% African American. South of Delmar Boulevard, the region is about 80% white. The Delmar Divide is such a graphic indicator of segregation that is so stark that it actually gained the attention of investigators from the BBC who were here to conduct a study on the Delmar Divide. And in the divide, as evidenced here in this graphic, they noted that north of Delmar is just pretty remarkable. As you can see, the 99% African American north of Delmar and 70% white south of Delmar. And you can see the disparities, the differences in educational attainment, in household income. And of course, we'll talk about the disparity in life expectancy based solely on racial segregation patterns that have persisted for decades here in St. Louis. So, what are those disparities? Let's kind of go into a little bit more detail here. The Regional Health Commission in 2003 actually developed a series of geocoded charts to really highlight the depth of the disparities in the St. Louis region with regards to race, socioeconomic status, and a number of health indicators, infant mortality, cancer. And you can see from this graphic, which is really looking at poverty, and the highest rates of poverty are coded red, you can clearly see the distinction that the significant amount of poverty is localized north of the Delmar Boulevard in North St. Louis. You'll see a crescent shape of red extending southward along the Mississippi River. That really reflects the new immigrant population that we alluded to earlier. But for the most part, poverty in St. Louis is a north side phenomenon. Within North St. Louis, there are several zip codes which are even more likely to be associated with adverse outcomes. And these we call critical zip codes. I want you to focus on one in particular, 63113 in North St. Louis, a region characterized by some of the highest maternal child risks, the highest sexual risks, some of the worst indicators in terms of life expectancy, and then poor health care access indicators. Now, let's contrast 63113. If you remember the first graphic that I showed you, 3 homes in North St. Louis, they were in neighborhood 63113. The second home I displayed was in zip code 63105 in Clayton. Let's look a little bit carefully at those 2 zip codes. And what you'll see are 2 separate and unequal zip codes that are separated by less than 10 miles. In 63113, the individuals born live births without first trimester prenatal care are tenfold higher in North St. Louis 63113 compared to Clayton, Missouri. Low birth weight is 3 times higher in 63113 compared to Clayton. Lead poisoning rates, again, 3 to 4 times higher in North St. Louis compared to Clayton. And in the final analysis, I posed the question, what is the life expectancy between an individual born in that home in 63113 versus 63115, and you can see the answer. There's a remarkable disparity. 66 years life expectancy in 63113 compared to almost 83 years in 63105 Clayton. Just remarkable. We can map perhaps every healthcare indicator to St. Louis region, and it coincides. The leading indicators coincide with the 63113 and other zip codes in North St. Louis. Here we've mapped homicides in 2017, and you can see graphically where those homicides are mostly occurring in North St. Louis. So with this being stated, I think we now can understand that our region is racially stratified, segmented, and there are remarkable differences in healthcare indicators between North St. Louis and the rest of the region. So it really should come as no surprise that individuals living in these communities would scream for help under the heavy burden of living with poor disease and poor health over years. And so Ferguson, to me, was not some epiphenomenon. It was a seminal event that should have been predicted, because Ferguson had less to do with the death of Michael Brown, the African-American teenager, unarmed teenager shot by a white officer, and more with the circumstances in which Michael Brown and so many lived. Circumstances that are highlighted by high rates of poverty, high rates of infant mortality, high rates of unemployment, and less educational attainment. And so when you take those factors, and then when you layer on police brutality, racial profiling, discrimination in municipal courts, then you can understand why Ferguson occurred and why Ferguson can occur again in another part of our region. So how did we get this way? What happened? Let's delve into this in a little bit more detail, and I want to give you a brief history of St. Louis. I think you'll get a better sense of why we're this way and how can we then find ourselves out. How can we find a path forward? St. Louis started as a very wealthy city, founded by French fur traders. There was significant commerce in the Mississippi River, and so the city was bustling at the turn of the century. I love this image of the East Bridge connecting St. Louis to East St. Louis with remarkable industry on both sides, and this movement back and forth between St. Louis and East St. Louis. East St. Louis in that area had a lot more nightlife, and I think that kind of led to a lot more excitement on the east side of the river. But they were still viewed as a region together. But something happened. Landowners, the reigning gentry, business leaders recognized that their economic interests were not served by subsidizing the expansion of the infrastructure to the rural areas, what would be in the future St. Louis County. And so they wanted to keep the largesse of spending in the St. Louis city proper. And through a very narrow decision, in 1876, the city decided to divorce from the county. The city actually seceded from the county. So Howard Baer, in 1978, concluded that this action was roughly the equivalent of England's giving up the 13 colonies, only the city did it from choice, whereas Great Britain at least had a good sense of struggle, but half-heartedly, against the separation. So St. Louis was wealthy, and we hear about the St. Louis World's Fair in 1904, and we're thinking, my goodness, it's 2018. Why are we still talking about the St. Louis World's Fair in 1904? It really was an opportunity to showcase the wealth, the opulence in this city to the world. We were proud of that. And there were many others, particularly health professionals, who were proud of the enlightenment that was occurring in St. Louis at the turn of the century. John Green, who was president of the St. Louis Medical Society, stated that if we have these resources in St. Louis, if we have this spirit of enlightenment, can we not extend this to a medical enlightenment? Can we then create a hospital system which will benefit our less fortunate citizens? And will this actually provide instruction in medicine to undergraduate students? He was really prescient in saying that we can provide a system of care that will uplift the entire region. And unfortunately, his advocacy was not realized by those who were structuring the healthcare system. The first city hospital, the second city hospital, actually the first one opened in 1846 and was destroyed by a cyclone, but the first major city hospital opened in 1906, and unfortunately it opened as a segregated facility. African American physicians were not invited to the hospital, they were not extended privileges, and African American patients were relegated to residing in the back part of the hospital. This was at a time when Plessy versus Ferguson was a law of the land. It was separate but equal. Now, St. Louis still, even in the setting of Plessy versus Ferguson, was a relatively progressive region. St. Louis is mostly southern, let's be honest. And there are some southern mores which still are here. But as you can see by this integrated swimming pool, that there were certain practices that were really tolerated in St. Louis. However, something changed. And what changed was the remarkable migration of African Americans from the Deep South between 1915 and 1970. This is what Isabel Wilkerson wrote extensively in her book, The Warmth of Other Suns. She chronicled the epic migration of African Americans seeking greater greater opportunities after being oppressed in the South for hundreds of years, moving into communities that would hopefully provide those opportunities. But this was at a time in the middle of World War I when our economy was unfortunately doing less well, and families like this one arriving in Chicago found themselves, when they were seeking employment, pitted against white low-income workers who found them to be a significant threat, an economic threat. In St. Louis, and particularly in East St. Louis, this all reached a head in 1917 when African-American workers were trying to find jobs at the aluminum ore company in East St. Louis, while white workers were boycotting. They were striking. Seeing the African-American workers arrive, unfortunately, tensions brewed and they boiled over and culminated in one of the worst race riots in the history of the United States in 1917. You can see on one image whites pulling African Americans out of a streetcar, and on the right side you can see homes, African American homes were simply burned to the foundations. This was really a horrific time in the history of St. Louis. Even before then, white landowners had written into law restrictive covenants which prohibited whites from either renting or selling homes to African Americans. These were written into law in 1916. Although they were declared unconstitutional by the U.S. Supreme Court, frankly, they continued unabated for decades, well into the 50s and 60s. And after the East St. Louis riot in 1917, African Americans fleeing for their homes, for their safety in East St. Louis, came across the East Bridge looking for refuge. And they were told that if they wanted to be in St. Louis and reside in St. Louis, they could not live south of Delmar Boulevard. There were just harsh restrictions. So this is a map of restrictive covenants shortly after the East St. Louis riot. And there's a certain phenomenon that hasn't changed here. Not only were blacks relegated to living north of Delmar Boulevard, if you were Italian, you had to live in the Hill. And if you were Jewish, you had to live in either Kingsbury or University City. And if you were German, you were pushed up north, to Baden, Riverview. We're at 2018, and frankly, some of these housing patterns have not changed. Well, here's an image of an attempt to really explode and just collapse that entrenched segregation, the collapse of the Pruitigoe housing development in 1972. Hopefully, this was to be the sign of progress for St. Louis as we move beyond entrenched segregated housing to providing mixed income housing across the region. Unfortunately, that did not come to fruition. The residents of Pruitigoe were similarly push further north into North County suburbs also, and housing patterns remain segregated. Let's talk now about healthcare in St. Louis, since we've had that type of history about the political and social cultural events. So here's a picture of our hospital, Barnes Hospital, around 1915, and there's this beautiful structure. There are in the foreground 2 smaller frame houses. These were the hospitals for Negro patients at the time, African American patients. This was to the embarrassment of a lot of the trustees at Barnes Hospital at that time, and so those facilities were dismantled shortly after this picture was taken. But frankly, African Americans still resided in the basement of Barnes Hospital for care well into the 1960s. African Americans were pushing for their own hospital, not wanting to live in the basement, or not having a place where they can receive equitable health care. The city number 2 was, in a short time frame, woefully inadequate to meet the needs of the African American community. And so an attorney in St. Louis, Homer G. Phillips Hospital, became the main advocate for a larger facility for African Americans. And he was successful in winning a significant award from the U.S. Department of Interior, along with significant bond to build a city hospital for African Americans. Unfortunately, Homer G. Phillips was assassinated before his vision was actualized by a mystery still to this date. But his legacy was the Homer G. Phillips Hospital, which was constructed in 1937 and was widely heralded as the largest Negro hospital in the world. It was a beautiful sight. It really was the largest Negro hospital in the country, if not the world. And between the dates of operation from 1937 to 1979, 1 out of 3 African Americans completed their residencies in this hospital. It really was state-of-the-art in every respect, in terms of this infrastructure, the training in conjunction with Washington University, as well as the high-quality care delivered in that hospital. Toward the 1960s, as the city of St. Louis population declined, peaking in 1950s and declining, the city was unable to support 2 public hospitals, City Number 1 and City Number 2. The mayor at the time actually charged 2 commissions to look into whether or not which one of these 2 hospitals could actually remain solvent, recognizing that the tax base was not there to support both. Both commissions agreed that Homer G. Phillips Hospital was the better hospital in terms of its physical structure and its overall quality of care. Nonetheless, Homer G. Phillips Hospital, the predominantly African American hospital, was the one that closed in 1979 under remarkable protest. It was a dark day in the history of St. Louis, and it's a memory that's really fully carved in the minds of those individuals of color in this city to this day. Unfortunately, with that history, we continue to see a decline in St. Louis City population from its peak in the 1950s to current of about 315,000 individuals. The last public hospital was St. Louis Regional Medical Center. I had the honor of serving as chief medical officer, and seeing that history really allowed me to be able to speak really candidly, having spoken to the physicians, the nurses who actually live through those wonderful and tumultuous years of Homer G. Phillips Hospital. Now, so I've given you that history, and I don't want anyone to leave here thinking, my goodness, all is poor, woe unto us. Some things are beginning to improve. And through the collective efforts of the St. Louis Regional Health Commission, which was chartered in 2002, we have seen health indicators improve. The Regional Health Commission actually began to look at areas in North St. Louis. I mentioned those zip codes, 63113 among others, and recognized that we could do a better job of coordinating care among the federally qualified health centers in those zip codes. And as a consequence of that and the creation of the Integrated Health Network, we have begun to witness some improvements in the healthcare across the region, particularly on the north side. As you can see that we've seen, in the period of 2000 2010, we saw a 29% reduction in heart disease mortality. Diabetes mortality fell by a similar rate, as did stroke mortality and even lead poisoning. However, for young people who are less likely to access care, particularly young African Americans who are less likely to access care, that population was unfortunately characterized by the latter rates, an increase in sexually transmitted infections and unfortunately an increase in homicides. So what have we shared so far? So far, we've talked about two communities, one black, one white, separate and unequal. That was a finding of the Kerner Commissioner by Otto Kerner in the 60s after the civil rights riots in Watts and Detroit. But we can say the same thing about here, our own region in 2018, separate but unequal. We have communities of opportunity, and we have communities, health disparities, low-income communities. And those communities are basically can be stratified based on the collective number of goods and services, the social determinants of health that we alluded to earlier, the access to transportation and grocery stores and financial institutions and better performing schools will give rise to communities of opportunity, whereas, in contradistinction, poor performing schools, limited public transportation, food deserts are associated with our low income communities and thus poor health status compared to the communities of opportunity with their excellent health status. Well, we've also talked about the social determinants of health, that our health status is really undergirded by access to affordable homes, living wage jobs, ability to obtain an education, the ability to live above the poverty line. These are factors which are more responsible for our overall health than the health care that I can deliver as a clinician in my office. Lastly, I hope that this presentation allows us to recognize that these disparities persist based on social cultural phenomenon. In this graphic, 8 out of 10 white practitioners believe that disparities in how people are treated within the healthcare system rarely or never happen based on such factors such as English fluency or racial background. And when they do acknowledge racial disparities, physicians will say, well, these disparities occur in the U.S. healthcare system, but they don't occur in my hospital or my clinic. And even more disheartening are these beliefs that persist among U.S. residents, medical residents that is, and medical students. Even now, a quarter of residents in medical schools will believe that African Americans have thicker skin than whites. And there are other false beliefs that are perpetuated in our medical system. And so because of all these factors, it's really incumbent upon us to delve deep into this history, to recognize that in order to understand health disparities in communities of color, we must get out of our comfort zone, we must get civically engaged, and we have to have a greater sense of how do we train ourselves to mitigate the bias that we all have and to become more aware of these disparities. How do we incorporate questions on social determinants of health in our medical histories? And how do we recognize that individuals who are living in these certain zip codes, North St. Louis, who live under daily trauma and high stress, how do we begin to deliver care that asks, what happened to you rather than what's wrong? How do we deliver trauma-informed care? These are things that we must do now. We have to do if we really are sincere about wanting to reduce disparities and ensure that every St. Louisan has the opportunity to reach their full health potential. There are opportunities for residents, there are opportunities for students, and in my final statement, I would say a lot of this is not based on giving a certain level of understanding about disparities other than giving a certain level of understanding about how do we treat people, how do we treat our patients. And I think Francis Peabody had the most salient statement when he stated in 1927, one of the essential qualities of the clinician is interest in humanity, interest in caring. For the secret of the care of the patient is caring for the patient. I want us all to care for the patients in our region. whether those patients are from North St. Louis or South St. Louis, whether they're from Ladue or whether they're from downtown St. Louis, whether they're African American or whether or not they're white or whether or not they're Muslim or Latino. And we're all St. Louisans. And when we all are really supported around this sense of caring, of uplifting the entire community, then we will have opportunity to see all of us reach our health potential, and then we will see the demise of crippling health disparities. Thank you.